present the next presenter, Dr. Abdulrahman Almoghairi, to start his presentation on TAV and TAV keys.
Assalamu alaikum. I have two cases. One is using the balloon expandable in failed self-expandable, and the other one is the self-expandable in failed balloon expandable. So there is no immune, no valve is immune from the degeneration, and all the valves are equal for this one, and the literature is full of this kind of evidence. So the first case is the elderly patient with multiple comorbidities with TAVR self-expandable implanted in 2018. So it's due to degenerating from 5 to the average is 5 to 8 years, and maybe now with the new modifications and engineering and extending the lifespan of the valves. And the patient had the echo, which showed severely degenerated valve, normal echo. The pathology is the AI. And the AI usually raised the suspicion of the underlying cause might be the infection and making the valve destructed due to the infection. So the extensive workup for the endocarditis done and was negative. And the coronary angiogram patent stent prior to the new valve or new planning, and the patient underwent the full workup for this to prepare him for the procedure, and his presentation started very short. So probably once the valve started degenerate, the deterioration it happened very fast. That's why once we detect the degeneration, we should work the patient fast before they go into the complications, which is the heart failure. The sudden death is also is not low in this patient. And this is the procedure. We had the CT, but I failed to upload or to add the images. And this is the valve. So it's the first valve, of course, implanted. And this is the procedure. The implantation depth is good because this will help us in planning the new valve. This is the original one in 2018. So the valve was good. The result was excellent at that time, and the echo is good. And now the echo after the degeneration, and as we see here, is the valve degenerated, and this is severe aortic regurg. And the T done part of the workup for the endocarditis. And the TAVR expansion to young patients makes now the selection of the valves. Which valve to start first? Is it the self-expandable or balloon expandable? Is it the intra-annular or supra-annular? To keep in mind the access to the coronaries for the old valve and the next valve, the first valve and the next valve. Then the commissural alignment to help also for the future procedure if needed. And the indications for the intervention or re-intervention for the degenerated valve, either structurally deteriorated or valve due to destruction due to infection or other reasons, or due to the severe paravalvular leak and you want to expand it with the valve, new valve to increase the radial force. Sometimes the self-expandable follows the anatomy, especially in the elliptical shape for the bicuspid. And the technical challenges associated with this is the risk to the coronaries, the positioning and sizing of the valve also is very important to keep in mind, the alignment with the coronaries to allow the access to the coronaries, in addition to the procedure itself for the implantation, pre-procedural CT, and also the which frame to choose, and the need for the cerebral protection, because we know the degenerated valve is associated with high burden of debris, and it might need the protection to the upper. And then the aligning the valve, the new valve in relation to the old valve. Are you going to follow the description which is described in the literature, going by nodes, or going by the three parameters, the coronaries, height, coronaries to the valve, and also the sinotubular junction also, and the position of the original valve, the old valve, is it high position or low position, and to consider the leaflet modifications if need. If the position, the original position is high, that means the sinotubular junction is at risk. So you prepare yourself to modify the leaflet to avoid the coronary obstruction. And after the extensive planning, then you go to your to the valve and choose. And the most important is the coronaries for the acute success of the case. So whether you use the nodes or you use the VTC and the valve to the sinotubular junction is very important, and to keep in mind. If the sinotubular junction is wide, so the risk is low, even the VTC is low, because the supraannular valve, it's the leaflet, it may work as a skirt and block the flow to the coronaries. In this valve, the risk was low, the coronary height is reasonable, the sinotubular junction is wide, and also the valve position is reasonable, is not high. And deploying the valve slowly, and keeping in mind the relation to the coronaries, and using the angiogram to help you. Once the valve is not fully expanded and slow going, still you can modify either going down or up according to the need, and the valve deployed successfully, and the result is excellent. No BVL, no regurg, and the no coronary obstruction. And in this case, we did not use the cerebral protection. Because of there is some anatomical in the subclavian difficulty to use it, but we should consider it for every valve and valve, because this is the highest risk in spite of the evidence. Maybe the evidence for native is weak, but for the valve and valve, and this is the EcoBoost valve. It's good positioning, good valve function. There is no regurg, and the MR was moderate and disappeared now. And thank you. This is for the first case.
Congratulations, Dr. Abdulrahman. This is a very nice result. There's lots of questions and discussion points here, but maybe I'll start with Dr. Nabil. Positioning those valves can be tricky sometimes, and this is a degenerated tall frame valve where Dr. Abdulrahman put in a short frame sapien valve. Would you elaborate on positioning the second TAV valve in this case?
Yeah, so now when we position this short frame into a long frame evolute in this case, our outflow of the second implanted valve will be either at node 4, 5, or 6. So when we go at node 4, that means we are going deep. Basically, that would give us the lowest risk of coronary obstruction. However, there will be a leaflet overhang. And the opposite exactly happens if you go to node 6, where leaflet overhang will be very minimal, almost zero, but the coronary risk will be high. So we decide based on of course, the coronary height and the mechanism of the valve degeneration. So if the valve degeneration had a leaflet stenosis, then probably going higher implant versus low would be preferable. But in this case, because of the degeneration is an AI, you can go at node 4 with very excellent result, as Dr. Abdulrahman mentioned.
I think this is a very important point. The mechanism of failure decides on the positioning of the valve. So if you have primarily stenotic valve, you want to cover the functional leaflet, which ends at node 6. But then you're going to run into higher risk of corneal obstruction. Here, the main issue of degeneration was severe AI. So it's acceptable to deploy a bit lower, protect the coronaries, and get a good result. Maybe question to Dr. Faisal Al-Ghoufi. This patient had a TAVI 7-8 years ago. Do you think that's a reasonable, durable result? What would you quote your patients in terms of longevity of valves when you offer them TAVI?
Yeah, so this is again back to the durability and the lifetime management, which is an important discussion of our current TAVI clinic. Currently, we are quoting 8 to 10 years. The mechanism of failure for this valve is the usual mechanism for a porcine type of valve. Usually, they fail with AI. The important discussion in the first visit is actually the choosing the right platform for a patient to cover the 2 period of needing an intervention. I divide them by 8 till 10 years, and then what's going to happen after 10 years. I do believe the durability of this valve is very reasonable. 2018, 8 years. It's within the ballpark that we are currently coding the patient.
I see our surgeon is not happy with the result. Would you, Dr. Mohammed, would you think surgical valves last longer maybe, or what do you think?
I was agreeing with my esteemed colleague that it's probably within the realm or the ballpark of what we normally quote patients. Surgical valves, some surgical valves and some reports have lasted around 15 years. And this again goes back to emphasizing the lifetime management and a collaborative spirit, combined decision-making process between the surgeons and the interventionalists to reach the best available option for our patients. It's really important. As the indications for TAVR are relaxed with asymptomatic patients now indicated to get a TAVR, to really think about the next stage. Younger patients are going to get TAVRs, and if we're not sure that the second valve is going to be another TAVR, we really need to sit down and decide what's the best valve choice for this patient.
Those are very good comments. Maybe last question, Dr. Mohammed Al-Banna. Now, if this patient is not a surgical candidate and you're going to go back and open the chest and explant this tall frame valve, how complex this procedure will be? And will you need to do a root replacement or repair the aorta at the same time?
So in a 86-year-old patient, whatever you do, the procedure is going to be complicated and is going to be fraught with high risks. Having said that, going back, surgically extracting a TAVR valve is fraught with high risk. Now, the available literature looked at or was looking at, we're talking about an era effect here. We have implanters with minimal experience. We are looking at valves of first generation. And thus, going in emergently is completely different than going in 8 years down the line. Many of the reports, the mortality risks range from 10 to 40%. And I think the 40% reflects the fact that someone was taken emergently post TAV implantation failure. In these patients, especially after a longer time after implantation, TAV implantation, 30% of the patients will require a root enlargement. I think we've had back and forth discussions about balloon expandable and self-expandable. Ali is in favor of balloon expandable, thinking that in the future surgery is going to be less risky. Unfortunately, both have similar rates of root enlargement, associated surgical procedures. The only difference is that patients with tall frame required ascending aorta intervention at the same time.
Well, I'm certainly in favor of the best result for our patients. Maybe we can go ahead with the third case, Dr. Abdulrahman Almoghairi. Thank you.
So the second case is the opposite, degenerated short frame and the treated with the long frame. The patient is an elderly again who had the pulmonoexpandable valve 2017 and the, with some residual mild paravalvular leak. And the comorbidity is more or less the same. He had a history of GI bleed and the limited mobility because of fractures consistent with his age. And the patient seen in the clinic with the symptoms and the admitted with decompensated heart failure prior to the procedure. And he has the chronic anemia due to either chronic bleeding or anemia of chronic illness. And this is his workup for the to evaluate the valve. There is a stenosis and regurg in the same time. So it's a severely degenerated valve after maybe 8 years or so, 8-9 years. Valve severely degenerated. So the CT planning and the similar to the previous valve, the valve assessment, also the sinuses, sinusotubular junction, coronaries, now to prepare for the new obstruction, because now we will implant the long valve and should keep the sinusotubular junction again in mind. And the coronary access also should be considered for all valves and valves, TAV and TAV in general. And those are the risk of coronary obstruction, either low-seated anatomy, narrow sinuses, narrow sinusotubular junction, the bulky leaflets, because the bovine valve is very bulky compared to the porcine, which is thin leaflets, and also the tall frame in the sinusotubular junction now is added to the risk. The stroke, if you consider the cerebral protection device, the risk of stroke in general is 1 to 3 in TAV. And also the types of the cerebral protection, either to protect from the ascending aorta or from the to select the common carotids. And some of them FDA approved, like the Sentinel. Probably we will see more devices. Now is available more than 8, but the FDA is given to the Sentinel so far. The evidence of trials in general is it's not making it at class 1 until now, but is in selected cases maybe is reasonable. And one of the selected cases is the valve and valve in general. It's either TAV and TAV or in surgical valve and severely calcified anatomy. There are some limitations, either anatomical or procedural related. Those are the limitations. And the cost benefit also is very important for this, because it is expensive beyond the level of the evidence to support it. So the cost is outweighing the benefit since the stroke rate is very low. And this is the CT planning for this case. So as we see the measurements, and then you in this valve, you have to prepare the bed for the new valve, because as we mentioned, is the bulky leaflets, bulky valve, so we have to predilate to make it ready for the self-expandable and to avoid the post-implantation technique. And the crossing the valve techniques is important, either to cross with the catheter or to cross with the soft wire, then followed by the stiff wire. And using the stiff wire to align it and to make it coaxial is very important. And this is the implantation of the valve. as we see here. So is the valve implanted after the pre-dilatation. The coronary visualization is excellent, and the valve is expanded well, followed by the hemodynamic assessment if we need further post-dilation or no, because as we see from the floor, you see it likes the valve is in the upper at the waist is not, it looks not expanded, but the hemodynamics are good. And this is, in general, the valve is supraannular and opening nicely. And this is the final image. Echo, after that, the gradient is low, it's not high. There is no regurg. And in conclusion, the long frame offers better hemodynamics. You can use the short frame and short frame, but the long frame maybe in some anatomy is. And the elderly patients, you are not going to expect longer half-life beyond another 8 years. And thank you.
Thank you, Dr. Abdulrahman. It was an excellent case demonstration of a long in short as well as short in long. My question to Dr. Faisal, now, like this case, this was a failed short frame valve with a PVL as well as intravalvular pathology. How would you optimize these patients before considering TAV and TAV?
Thank you. Great cases, Abdulrahman. I think the pre-TAV ECT is very important to look at the failure or how did your valve fail? What is the expansion of the valve? Is there any room to actually optimize the old valve, specifically a short frame valve compared to a self-expanding valve? The nuisance in those valves, if you are deploying the first valve in a calcium nodule, for example, and the reason for the PVL is a calcium nodule, then probably a second valve may or may not fix the problem with the new skirt. So it's very important to look at that mechanism before. I think we plugged 2 valves over the years specifically for that mechanism using a paravalvular leak closure. But in general, I spend sometimes in the CT scan. And also there are some, I think the Vancouver group where Ali came, actually, there is a good motion for optimizing the previous valve. Dr. Ali can comment to that, like specifically for a Sapien valve. If there is under expansion. So I think starting with, in a short frame valve, starting with a good pre-dilatation, looking at the result, I think we need to understand more if we leave those valves with only pre-dilatation, are they going to reach stenosis again or not? But there is some option with this short frame valve.
So this is a great point, Dr. Faisal. We mostly see a lot of TAVI valve failing when we do a pre-valve and valve CT. You see the valve is underexpanded. And what we realize is THV underexpansion is extremely common. So in your case, it was a 26 millimeter Sapien 3 valve, but on the CT, the average diameter is only 23. So despite implanting a Sapien valve at nominal volume, we realize these days, just by doing lots of those patients' CT scans, you often end up with THV underexpansion. Maybe optimizing the index TAVI procedure will give you a more durable result. But I guess there's still lots of work to be done in terms of how to recognize underexpansion, how to optimize results, at the same time avoiding the risk for annular complication with post-dilatation or risk of pacemaker or stroke.